Okay, it looks like our intro is not going to intro us today, so we'll just go ahead and get started if that's okay, Simon. So I'd like to just say good afternoon to everyone and welcome to Black Health Trust for today. I'm Dr. Ivan Walks. Our founder, Dr. Maxey, is unable to be with us today, and Dr. Barbara Neighbor Stevens is traveling today, as am I. But we're going to go ahead and get started. I think Dr. Jocelyn Hines may be joining us in a little while. Today, we are going to focus on a significant challenge for a lot of folks in a lot of places, but particularly in the African American community in the United States, and that is the challenge of infant mortality. So, Simon, if you could go ahead and run that for us, and we'll see if we can move ahead. Okay, we appear to be having some significant technical difficulties. Okay, if we're not able to run the infant mortality tape, then we will do what's called, there we go. Okay. So I'm not hearing any audio, Simon.
And to share some important information from very credible sources. But first, let me introduce my co-moderator, Dr. Ivan Walks. Dr. Ivan Walks, for those of you who join us every week, know he is a very established and experienced psychiatrist, but also a public servant, having spent several years in the role as Chief Medical Officer for the District of Columbia, as well as providing advice to our national leaders and helping to set public health policy. He has his firm that is involved in psychiatric practice and has been such an addition to the Black Health Trust group. He is the one that manages to keep us all on an even keel.
That's why we're in trouble. Please move on to the important people.
And with that, let me quickly move on to our first speaker. Our speakers today are sharing insight and expertise around the travesty that is occurring in this country around Black infant mortality. Our first speaker is a maternal fetal medicine specialist, and I especially wanted him to join us today because his role is to get the mother through a pregnancy so that the child is delivered. But as you're going to learn, there are a lot of things that can impact that journey. And Dr. Haywood Brown is going to share some of those insights with us. Dr. Brown has spent many years in clinical practice as well as in academic roles, having been chair at Duke, and now serving as Senior Vice President of Academic and Faculty Affairs at University of South Florida here in Tampa. Dr. Brown also is a past chair of the American College of OBGYN and used that position to help advance the cause of Black maternal health and mortality. So you will see very shortly that he is certainly an expert guide through the preconceptual and pregnancy phases of early childhood. Dr. Brown?
I think there may have been an issue with Dr. Brown's connectivity. I would fill in right now, and let's give him a moment.
Dr. Neighbor-Stevens, why is this topic so important to us?
This topic is so important to us because we lead the world in the developed world, in infant mortality. And in the United States, and I'm not going to steal the thunder from some of our speakers, but I will say that our babies die at twice the rate of white babies in this country. I see that Dr. Brown is back.
I'm sorry, I lost my internet as particularly, so I'm trying to figure out how to get it back, but I'm on my phone, so we should be in good shape. Can you hear me?
We can hear you.
Okay, great.
You're on.
Sorry about that.
No worries. Glad to have you back.
Go forward with your presentation, Doctor.
Okay. Well, thank you all very much for having me to present this important topic. And you have control of my slides. As Barbara has said, I'm Haywood Brown. I'm a professor of obstetrics and gynecology here at the University of South Florida. And one of my initiatives, of course, for a number of years has been Black infant mortality and maternal mortality. I served 20 years as the evaluator for the Indianapolis Healthy Start program, which is geared toward Black infant mortality. Next slide. So this is a slide of Dr. Ezra Davison. Dr. Davison was president of the American College of OBGYN in 1990. Many of you may know his name. He was a tremendous leader, and he basically was the person who started the Fetal and Infant Mortality Review Program. And I was fortunate enough to be the second Black president of ACOG in 2017. And Dr. Ezra Davison actually was one of my escorts. And of course, he unfortunately died the year right after that. And I was scheduled to give a talk for him in his honor at the National Healthy Start program. And he died several weeks actually before that event occurred. So he is dearly missed and really set the groundwork for fetal and infant mortality review. Next slide. So this is basically just the infant mortality wealthy countries map. And again, I'm on my phone, so I can't see these very well. But as you can see, we are really not doing very well here in the United States when we talk about infant mortality. Whether we talk about being 21st or 31st or 25th, it really doesn't matter. The reality is there's so many other countries that are doing so much better than we are. And again, we are one of the wealthiest countries in the world, and it's really a travesty. Next slide. So why is preconception care so important for women and also interconception care? Well, we know that, first of all, pregnancy spacing does decrease the risk of prematurity. It also improves pregnancy outcome. And so one of the things that we know is that infant mortality, particularly for Black women, is related to preterm birth primarily. Some of the leading causes of infant mortality, of course, number one is congenital anomalies. And that is related to a number of different things, including diabetes and so forth and so on, and birth defects. But chronic medical conditions as well lead to preterm birth, such as preeclampsia and all those type of things. And of course, low birth weight is a generational thing that we must deal with prior to small for gestational age infants. As you all know, 50% of pregnancies are unplanned in the United States, and maybe more so than we realize. And of course, unplanned pregnancy also is associated with a more adverse pregnancy outcome. And of course, we also recognize the fact that poor reproductive health leads to generational reproductive health issues, and all women and men should develop a reproductive life plan. And I include men particularly because I'm going to talk about some data today on fathers and the importance of fathers in this whole cascade of prematurity and infant death. Next slide. So one of the things that we know about preconception care is an intervention aimed at identifying and modifying behaviors. And so in reality, whether you're smoking or whether you have, whether you're anemic or whether you're whatever, many of these type of things increase the risk for adverse pregnancy outcome. And so emphasizing the factors that can be added upon prior to conception in early pregnancy, such as this simple thing as taking a vitamin with a prenatal vitamin. And again, this has been the law of the land since about 1990s. We recognized that folic acid was associated with decreased risk of neurotube defects. But the data is even more profound than that, because when you think about folic acid and its contribution to lower risk for low birth weight and prematurity, that data is also pretty clear. And so preconception vitamins is very important. And I talk about this all the time with my infertility patients that I see in preconception consult, because they're trying to have a baby at some of the challenging stages of their life, many of them with polycystic ovary disease syndrome and insulin resistance, and having a folic acid is very important to their overall health and well-being. Next slide. So this just shows you a little bit about what has happened over the last 100 years almost since we've been keeping data. And you can see I show both of these slides because one relates to infant mortality and the other relates to maternal mortality. And I would say that, the product of being the product of the 50s, the early 50s myself, I was the first child of my mother's to be actually born in a hospital, and the rest of children were born at home. But the infant mortality rate in the 50s was significant. And of course, there are a lot of things that changed with regard to dropping the infant mortality rate, particularly in Black communities, including many programs that are out there. But what we've seen is that we still have significant disparity in maternal and in infant mortality, and a number of factors related to that we'll talk about today. Next slide. So this kind of shows you a little bit of the differential between Black and infant mortality and white infant mortality over the courses of years, and you can begin to see again Black infant deaths have always outpaced white infant deaths for a number of different reasons. And you can see where we are in the third to the last bar, the next to the last bar there. And of course, the second highest rate of infant mortality in this United States, of course, is in Native Americans. And we're talking earlier today about the importance of Native American health and so forth, and helping individuals who live in those areas. And this is a very important aspect for us to keep in mind as well. And some of the programs that are geared toward Native Americans is very important to their well-being. Next slide. So this is about racial disparity in infant mortality. And again, what you can see here is that we see what has happened over the years, but you can again look at the lines there and see where the differences in Black and white infant mortality and Native American infant mortality. And I know that some of my colleagues are going to talk about some other aspect of this in just a little bit, but this is extremely important for us to keep in mind that this disparity still exists. And many of the factors related to prematurity really are related to stress. And so as I wrote a paper for the National Medical Association was published in January, that talked about generational stress, and we're talking about Juneteenth and coming out of slavery. In reality, believe it or not, pregnant women receive the best care of any of the slaves on the plantation, because they were part of the wealth of the slave owner. I mean, they really didn't care that much about the children that were being born as much as they did about keeping the mother healthy and keeping her able to get another pregnancy and so forth and so on. So the reality is, at the end of slavery, going into particularly the rural South, women were still trying to be as healthy as they could be in cases of poverty and so forth and so on. But they had a nuclear family to really help them to gain many of the health advantages that they got as best they could. But keep in mind that low birth weight and prematurity and infant mortality were certainly significant then. And of course, they continue to be much more profound today than they need to be. Next slide. So this basically tells you a story here of looking at where infant mortality is today. And notice that the rural South still has a significantly higher infant mortality than many of other states. And I want to also remind you, as we talk about extension of Medicaid and expansion of Medicaid and so forth and so on, where have we not done this? We've not done this in most of the rural South. And these are the old Confederate states of the United States. And of course, the reality is, just as they fought against having Medicare in 1965 because it was tied to integration of hospitals, they also fought having Medicaid. And of course, expansion of Medicaid became a real bad term on Capitol Hill when I was there. But even though we're seeing some states now, including Florida, who are willing to extend Medicaid because it's associated with so much money coming down the pipe. Next slide. Now, this is an interesting slide, and I pulled this years ago, and it says if Alabama were a country, its infant mortality rate of 8.7 per deaths per thousand would place it between Lebanon in the world rankings. Just think about that. Just think about that. And so we're talking about a Middle Eastern country. We could compare it to a number of different places as well, but this is not this is a factor that we need to keep in mind, particularly when we talk about just overall infant mortality in the southern states. But when we talk about the disparity in Black infant mortality in these communities is even quite more profound. Next slide. So this is another slide that I like to show, and that really is the income gap in infant mortality. Now look at this. What it tells you is that poverty is a factor. And when you tie poverty to racism and poor health care and quality of care, these are all factors that play a role in this disparity. And so the gap of income and how it has changed the whole landscape of Black infant mortality, you can see here. And so even though we talk about infant mortality crossing all economic gaps, and there are a number of reasons for that. And again, because I talk about stress as a factor, and whether you have Blue Cross or Blue Shield, you have Medicaid, you have no insurance, Black women certainly have more stress during their pregnancies, whether they're lawyers or whether they are working in healthcare or whether they're working at the front desk or something. I mean, the factors are very real in regard to those types of things that we know play a role in health outcomes. Next slide. So these are some specific hypotheses on stress and prematurity. And I really won't go through this except to say we know that and I have a lot of colleagues on the phone who can here who can appreciate this. Stress is associated with inflammatory cytokines. And inflammatory cytokines are really one of the factors related to preterm birth. And so, as you know, when we get stressed, our cortisol levels go up, our blood pressure goes up, our pulse rate goes up. And of course, if you don't have time to kind of unwind from those type of things, as we know, stress leads to heart disease, and the uterus is just another smooth muscle and responds to those pro-inflammatory cytokines just like that. And so the reality is perceived stress, or how we respond to our stress, is very important in terms of someone sent me an email this morning, and it was really related to something at work. And I said to them, I plan to have a stress-free day today. So I really don't know why you're sending this to me at 7 o'clock this morning. I mean, on Father's Day, no doubt. And I said, we're not going to deal with this. We're going to deal with this on Monday. So the reality is that that stress is a factor and that plays a role in African Americans and their response to pro-inflammatory responses. And so you think about pouring racism into that as well, which also increases your stress rate. African American women are at higher risk of preterm birth as a result of their relationship between that stress and the pro-inflammatory cytokines that they enact with regard to that. Next slide. So this is the prematurity report card, and this is something that the March of Dimes does every year again. And you look at the dark red, these are people with the F report cards. You can also see the D's and the C's on that report card. And what do you see again? You begin to see the South, the same group of individuals who came out of slavery, who really were part of the sharecropping system, a part of the current mentality of being oppressed from a voter registration and so forth and so on, that are factors there with prematurity rates. Prematurity rates, leading cause for Black infant mortality. Next slide. So factors accounting for the prematurity differences in low birth weight, low risk whites and Blacks is the current health status, and talk about the childhood and adolescent health history as well, which play a role. I've already mentioned stressors, nutrition. We know nutrition is a factor, anemia in Black children. I don't need to tell many of the pediatricians on the phone that, because I grew up anemic myself, even though I didn't really know I was until I, realized when I got my college visit, oh, you're anemic. I said, I thought I had been eating pretty good, but evidently I was not eating and taking vitamins and doing the things we needed to do. And quality of medical care, as we already talked about those things. If you're greeted with, I call it evil intent at the front desk when you're going in for your prenatal visit and someone's stressing you out because you're there, it certainly does not improve your chances of having a good pregnancy outcome and a better health outcome. Next slide. Next slide. So I want to spend some time here in my last part of this today, really talking about fathers' involvement. And I've done some work on this myself. I used to teach what we call a New Fathers Boot Camp in the prenatal clinics, which really was more about trying to help the father bond with the pregnancy, father, develop their own personal awareness. And I did a survey looking at, how much did patients know about, how much did fathers know about pregnancy? How did they define preterm birth? Had they ever heard of postpartum depression? Simple things like that. And I did it across educational levels. And believe it or not, the graduate males had a tendency to calculate 9 months rather than 280 days. And so they always assumed that pregnancy was really less than 40 weeks. So paternal involvement during the perinatal period decreases the portion of infants born who are very low birth rate or preterm. And I'm going to show you some data that reflects that, not to get too hard on the data, but here you go. Next slide. So this is where it looks like in a study that was done by Leo and published in the journal Maternal Child Health, actually in 2010. And basically what you can see is that the relative risk of low birth rate, if the father was present in the home or the father was absent in the home, you can look at what happens if the father was absent. The relative risk of increase for low birth rate and very low birth rate and overall prematurity and very preterm was significantly higher. Now, we know that part of that is just relationships and having support. There's support and there's not support. It's one thing about being present and being supportive and decreasing stress. And this is basically what this is all about when you begin to kind of show this data. Next slide. So this is another factor, and we asked this question when we did our survey. The father's attitude toward breastfeeding. We know how important breastfeeding is overall, and there are many programs now geared toward improving breastfeeding rates in African American women, which have one of the lowest, some of the lowest breastfeeding rates. But we've done a very good job of those type of things. 75% of women make decisions about breastfeeding before pregnancy or in the first trimester. And 40 to 75% of women in this survey reported that the perception of their partner's opinion really helped them to drive that decision around breastfeeding. And so it really is part of the prenatal education when the partner's there to talk about the risk benefits of breastfeeding for their infant, And we know that there are many benefits for the mother, but clearly the benefits for a baby. And what we were able to demonstrate, even in our Healthy Start data in Indianapolis, that our adolescent women were more likely to breastfeed than the national average because we taught them about the overall benefits of breastfeeding, including less childhood illnesses and so forth and so on. And not to mention the fact that it was certainly much more beneficial and more cost effective to breastfeed. So even breastfeeding for 4 months actually decreases the risk for long-term adult cardiovascular disease in women and in their offspring. Next slide. So these are some of the lessons learned from our fetal and infant mortality review from the Indianapolis Healthy Start, and that is pre-existing maternal and infant conditions, poverty and prematurity were common themes in our case review of infant mortality, and pre-existing medical conditions and compliance with treatment, for instance, for diabetes and hypertension was also a factor. And motivating women and improving their mental health and dealing with substance and social issues was certainly a factor as well that decreased the chances of them having another infant death. Next slide. Next slide. Now, this is an area of my area of work, and that really relates to preterm premature rupture membranes, which is really when it occurs at 20 weeks, 21 weeks, and 22 weeks, where it really is the biggest contributor to extreme low birth rate. And what I want you to do is pay attention to what the recurrence risk is. If you look at women who have preterm premature rupture membranes, at less than 32 to 34 weeks, the risk of having it happen again is significant. And we know that this is where interconception care plays a role. And whether you're a big believer of progesterone or not, the reality is that for Black women, one of my biggest concerns with them now coming out with issues related to progesterone is that they really didn't take into consideration that most of the studies were not done in Black women. And now, as part of our NMA section of OBGYN, we're looking at this as a factor because we recognize the fact that progesterone may have positive effects in Black women just because of the environment and interaction and so forth and so on that decreases the risk for recurrence of premature rupture of membranes. And this is a reason that getting a patient back in postpartum and then following her up and having a good pregnancy spacing and getting her on progesterone is really a factor with regard to decreasing the risk. Next slide. So preconceptional risk factors for infant mortality and morbidity, we already talked about obesity as a factor, anemia is a factor, hypertension is a factor, diabetes is a factor, thyroid disease is a factor associated with, quote, neurologic health. And of course, seizure disorders are one of the leading, and the medications related to that are some of the highest risks for developing, having birth defects. And obesity is also associated with birth defects. So next slide. So if you look at just diabetes and birth defects, and we know, for instance, the higher the hemoglobin A1C, the greater the risk for heart defects in infants. I don't need to tell you all that on the phone, but if you look at this, the hemoglobin A1C of greater than 11.2% is associated with a 25% risk of anomalies. And so women who are going into pregnancy diabetic really need to make sure that they optimize their health. And this is certainly what we do very well with women with insulin resistance from PCO. Next slide. And obesity increases the risk for cardiovascular disease in adults and increases the risk for stillbirth, cesareans, birth defects, and so forth. And this is a factor also behind making sure that women try to achieve a healthier weight and don't gain too much weight during their pregnancy. Pregnancy is not the time to really have more excessive weight gain. And we need to really follow the Institute of Medicine guidelines. And what I found even at our own practice when I was at Duke is that people were less likely to talk to a woman who was overweight about how much weight she should gain, because they said, well, she's already gained all this weight anyway, so what does it matter? Well, it matters significantly if you talk about the increased risk of stillbirth, increased risk of cesarean, and the increased risk of birth defects, including dural tube defects. Next slide. And this really just kind of brings it to home. We've talked a lot about elective delivery at 39 weeks. And I would tell you that when you begin to look at the stillbirth rate in Black women, it is significantly higher beginning at 38, 39, and 40 weeks. And so for me, if you're obese and you're Black, this woman needs to be delivered early. She needs to be delivered no later than 39 weeks. She should not go to 40 weeks, 41 weeks. And one of the travesties, in fact, in our infant mortality review is that we had a number of women who were obese, who were diabetic, who didn't get delivered on time, and they indeed had adverse pregnancy outcomes, including stillbirths. Several of them in that study. Next slide. So preconception of folic acid, I've already told you, it decreases the incidence of spontaneous preterm birth between 28 and 32 weeks. What have I shared with you? Very low birth rate, increased risk of infant death. So have a significant effect, did not have a significant effect beyond 32 weeks. Again, the idea of a woman being on a vitamin 1 year, 3 months, 4 months at the time of conception is very important. Next slide. And so, again, these are the final factors, as Barbara wanted me to cover, the importance of prematurity and preconceptional health. Screenings for medical and social risk factors is the key. Providing appropriate vaccinations is the key. Counseling based on age and race and medical conditions. Health education. Why is it important to do these things? Not just it's important to do it. Talking about these type of things and talking about generational health, and ultimately healthy children produce healthy adults. Healthy children, healthy adults. And we used to say in the Healthy Start word, the health of a community is really about the health of its children. The health of a community is about the health of its children. And then my last slide should be coming up. So, generational stress and stresses in Black women from slavery to present are part of the fetal origins of adult disease, whether we're talking about hypertension, whether we're talking about obesity, whether we're talking about diabetes, whether we're talking preterm birth and infant mortality. And then you add to that segregation, economic inequality, inequalities in education, and systemic racism. They all have their impact on overall infant health, and as a result, have an impact on overall adult health. I think that's the last one, Doctor. Is that it?
Thank you so much. Thank you so much for this excellent top shelf lecture. Dr. Neighbor Stevens, may I ask him? That was so excellent for Dr. Brown to present again. And he is one of the top specialists in the country. And we appreciate him appearing again by repeat video. He brought up some substantial points that we're going to be able to talk about in our last few minutes with our co-hosts. I noticed Dr. Ivan Walks, Dr. Barbara Never Stevens with us. I don't know if Dr. Hines is on, but this fits into DI.
Simon, if you can go ahead and stop the tape, that'd be great.
Who love our people and love their kids and love their mothers to be, we're in trouble. What do you think, Dr. Stevens?
Well, absolutely, that's a fact. But what do we do about this? Well, as I have mentioned before, as far as this proposed legislation is concerned, we need to make sure that our representatives know our feelings about this, and we need to kill it, and we need to kill it double dead. But beyond that, I would like to again, and I don't want to harp on this, but I just want us to understand that our children need our guidance and support. Kids are struggling in schools right now. And so that community that is the village needs to really get to work and provide not only the nutritional supports and the mental health support that is certainly needed, but also that emotional support to let them know that they can master the subjects that are necessary to go into the sciences and math. And we need to not lose a whole generation from participating in the health sciences. And I don't believe in waiting for the savior to come on the horse. The power is with us, and the responsibility is with us to help take care of our own children in our own community. Now, churches get into one more thing. Churches can get into it by having Saturday schools or whatever they want to call it, vacation Bible school. They can do it whatever way they want, but they can jump in here as well as our being advocates in the school system. Now you can have it.
That works.
So, Simon,
So,
can you stop the
let me
video?
apologize in advance for any background noise that we hear. There is some Easter Sunday celebrations going on
Are you hunting?
around it.
Are you hunting Easter eggs? That works.
I
Simon,
can
if
find
you
them, but
hear
I'm
me,
too
can you
old to
stop
get
the
down
video?
and pick them up. So I just point them out. So let me say that I appreciate the lecture. The information is so important for us to continue to talk about. It is such a big public health issue, and there are different parts of our communities that things impact more. And as people to go to Dr. Neighbor Stevens' point, and I appreciate her passion about this, because if we let people pretend that there are no discrepancies, that there are no disparities, that there's no institutional problem that shakes out along lines of race and ethnicity, we are really setting the stage for bad outcomes for the next generation. So I think we have to encourage those of us that have that passion, and we have to speak out and speak up about it. And then I think we've got
Simon, can you hear me to please stop the video?
On this, I remember that you got to be in our community. We are so anxious to get to the point where everyone's treated the same, and we don't have these kinds of things. And many of the young people that I know are busy wanting to get away from discussions about racism. And I think that those are discussions we have to have with the tone that this is a problem, but also with the realization that we do have to work twice as hard and be twice as good. And guess what? We can do that. We can put in the work, and we can get the results, and we can succeed. So those are my initial thoughts, Dr. Maxey.
Thank you so much. I know this is Resurrection Sunday and people want to get back to their families. So we're going to have last comments, but I've been reading some science fiction books about military action. And in one series I was reading, they have a saying called OTF, own the field. And they're looking at football players owning the field, owning the force. And looking back to all of the talks that we've had over the past 4.5 years, it is so clear to me that we have to own this field. We have to own this DEI. We have to own the protection of our own people and not give it up and not say it's old fashioned but we have to own it. It affects our health, our children, our grandchildren, and this is serious. It's not something we can let just slide off our thing. So let's have final comments so people can get back to their holiday dinners. Dr. Walks, final comments.
So Dr. Maxey, my final comment today is, and I think we can say that it's in line with the ongoing struggles. One of the most powerful things that I've seen in a long time is a very short video by a woman named Carol Lawson, who was the head women's basketball coach at Duke University. And she gave a talk to her team. It's called Hand.
Hello. Thank you, Simon, for sharing a very important video. As I said earlier in this broadcast, Dr. Maxey and Dr. Neighbor Stevens were not able to be with us today. One of the very positive things about Black Health Trust is that all of our programs are archived, and some of the programs are able to be rebroadcast. And when we have absolutely world-class national experts come on and share with us, a lot of those messages need to be heard again, broadcast again. So today we had just a very useful statement from Dr. Brown about infant mortality and how it impacts our community. We are getting close to the amount of time that we are able to spend today. And I'd like to, on behalf of Dr. Maxey, see if there are any comments. I'll start off with our co-moderator, Dr. Jocelyn Hines. If you have any comments about our ongoing challenge with infant mortality in our community.
Sure. One of the things that I put a copy of the Mothers and Newborn Success Act that's actually come up to Congress several times that has components that would address establishing health programs, have HRSA have grants that are directed towards improving maternal health care, and encourage some collaboration between HRSA, the CDC, and NIH. It has come up several times, but it still has not been passed by Congress. So while we were talking on the video, they were talking about, legislative efforts. So I just want to point out to our audience that there are legislative efforts ongoing that we can, ask our representatives to support in this space.
Thank you so much, Dr. Hines. And I see Dr. William Lawson is on with us and has his hand up to make a comment. If we can get Dr. Lawson. Go ahead, Doc.
Yeah, I just wanted to know, and I'm sure that this has also been an issue. I was shocked to learn that the breastfeeding rate in our community is very, very low. Howard University had a program just to get women to do more breastfeeding. But again, it was discouraged because presumably African-American women are a bunch of drug abusers who don't want to give it to the babies. The other thing I've noted is that there are a number of different organizations that are happening in our community, 501c3 programs and so forth, but they aren't working together to bring together the tremendous resources that we have among ourselves. We do need to take ownership of our issues, and we do have the resources. We need to remember that. It's a matter of communications, working in concert to be able to address common goals and common features.
Thank you so much, Dr. Lawson. That is, it is such an important, and to go back to, I think, a statement from around the time of President Barack Obama's first campaign, where the statement was, "We are the ones we've been waiting for." And I think that's applicable when we talk about trying to change infant mortality rates in the African-American community. We are the ones we've been waiting for. We have to be able to do that. And everyone who regularly sees my contribution on Black Health Trust know that I'm liable to go off on a tangent. So Dr. Hines, if you can pull me back if I get too far afield. I think this is one of my primary concerns about so much of our conversation around women's health and choice, is that there seems to be this pulling out of a particular time frame, which is there is a pregnancy, and we have to get all excited about whether someone can keep their pregnancy, terminate their pregnancy, or what have you. And there is absolutely not anywhere near that kind of energy around making sure that folks are healthy. So if they do have a pregnancy, there's a better chance of it coming all the way to a positive conclusion. Or if the pregnancy does come to a positive conclusion, what about the baby? There seems to be just not that same amount of energy. And I would propose that there's a continuum between a healthy individual, a healthy pregnancy, a healthy child, and a healthy adult. And so without going too far afield, Dr. Hines, and corral me back in, I think that we just miss this obvious line of continuity. So I'll let you respond, please.
I would also just add to that, in the video when they were talking about, like obesity during pregnancy and how some of the providers wouldn't talk to obese mothers about weight because it felt like it was a lost cause. I think you see some of the things that I think that we see in maternal mortality are also kind of a microcosm of things that we see in our broader society and how our values are just in general. To your point about making sure that we focus on the health of the individual. I'll just stick with the analogy on obesity for a moment, right? Mm-hmm. So already in our diet culture prone world, there's already a space, well, if you're obese, you're lazy, you're all kinds of other things, right? All kinds of other negative things. And then when obese people who are pregnant then gain weight, oh, well, the world it's just a cycle of negativity in the same way that there was a whole movement around taking scales out of doctors' offices because people would get so anxious about having to step on scales when they go to the doctor's office to discuss their weight. It's no different for pregnant people, right? Like they're not always excited about, unwanted weight gain or unintended weight gain either. But with the emphasis, whether or not the emphasis on that problem was the overall health of your child in the long run, or staying within the recommended 10 pounds that you're supposed to gain because you were already overweight, oftentimes that was the messaging, right? You're doing it wrong, as opposed to this is about keeping the focus on, this is about the health of you and your baby in the long run. And I think, just to your point, sometimes just tweaking the message a little bit can sometimes help people come to a better place of understanding on why I'm asking you to do this, why I'm suggesting that you do this. Even for breastfeeding, I think breastfeeding, especially in our culture, if you think about whether or not the moms of today's young people breastfed, well, who are your mentors? Who are your guiding people, right? If they're telling you that, not to breastfeed, it's less likely that the new mom, right, is going to breastfeed. I am happy to see, though, that there are way more breastfeeding coaches and things like that are becoming a normal and standard part of the delivery process. Then you can facilitate it, because there was a time when the message was, it's natural, you should just know how to do it, right? And that's not the case. While it is natural, it's not necessarily something that, baby knows how to do and mom knows how to do. So again, being honest about the messages and how it's okay to struggle, because some people got a lot of judgment if they weren't successfully able to breastfeed and the like. So I think there are a lot of issues that lead to this same outcome that need to be addressed so that we can have healthy moms and healthy babies.
Wow, that is a profound amount of very good information that we need to have. I know we're getting close to the end of our time. I want to go back to something else that was in the slide presentation today, which talked about the influence of the prospective mom's partner in the decision to breastfeed. And if the other person involved And in today's couples and families, it could be the guy involved, it could be the other partner of same sex that's involved. Their opinion about breastfeeding can have a significant influence. From the slide we saw earlier, up to 70% say that is a factor. So I think that just a broader education about the importance of breastfeeding, a broader education across men, women, and others about how breastfeeding can positively impact the mom as well as the baby. It's just one of those things we have to pay attention to. To Dr. Hines' excellent earlier point, a lot of natural stuff ain't natural. A lot of ordinary stuff ain't ordinary. And if Dr. Neighbor Stevens was on with us today, we'd certainly get a nice dose of common sense is not common. We just have to be very clear that when we learn these things through study and through academic rigor, all the researches, all the articles, that's only half the battle, if even that much. The other part of the battle is how do we get information to folks in a way that they can use it, that actually changes behavior. Giving people information is great. Getting them to change behavior in a positive way is really the goal of communication, no matter what you're talking about. So I don't know if there are any comments in the chat. I tried to look earlier with my
in the chat. Hazel Tanner just wanted us to make sure that we remember too that there are doulas and community health workers that again are more available now, right, to help support mothers through their pregnancies. And the other thing I just will briefly say, it brought up a small, that space about the partners, the partner's thoughts on breastfeeding. But one of the things that I think that we could do just culturally, right, is have the dad be more involved in the pregnancy along the way, right? Like make that a cultural norm, that you go into those visits, that you're getting the education too. That's not a norm. We do this thing where it's like, okay, dad maybe comes to that one visit, or when there's something dynamic to show, oh, there's going to be pictures today, I'll go. But otherwise, we act like it's just mom's job, right, to grow that baby, and I'll see you at the end. But what the study is pointing out is it's a dual effort. It's a community effort the whole time. So we should do a better job of treating it that way.
Excellent point. So we're at the end of our time. Any additional final comments, Dr. Hines?
No.
All right, you said it all. It's interesting. This is my final comment. We can go back and pull out multiple nuggets, and we did for a few minutes from the presentation that we had. And this is why Black Health Trust programs are archived. I know we have some folks that join us on Zoom on Sunday afternoons, other folks that join us on YouTube, and then other folks still that go and look at the archived programs. This is really important information, and the fact that it's available is really important. The fact that other people can say, hey, by the way, there was something on Black Health Trust, is sort of like when you go to church and the sermon is something you want to share. It's nice if it's archived somewhere. Oh, go look up the service from so and so a date, because what the pastor was saying really mattered a lot. So with that, I am going to, there was also a comment from Juliana Taylor about the correlations between generational stress and the history of Africans being enslaved, to the point that how important it is that we can look at the research, we can draw these parallels, and we can continue to let folks know that all of that matters. And I want to make note, Dr. Hines, that I have spared our audience all of my comments about stress and mental health and its impact on this subject.
We're saving it for another time when we can give you the due time to.
Because we need a lot of time. So many things are impacting the mental health of our community and impacting the mental health of all of the health challenges and opportunities in our community. So with that, I'd like to thank Dr. Hines for standing in the gap and filling in and I want to thank Dr. Walks for filling in because boy, we really, and Simon, really want to thank you as always for being the rock upon which the Black Health Trust is built. So with that, have a great day, everyone. Thank you so much for joining us.